Check out the full episode of the Bendy Bodies podcast on your favorite podcast app. As you may or may not know, this podcast covers a lot about joint hypermobility, connective tissue disorders like the Ehlers-Danlos syndromes, comorbidities like POTS and MCAS, and the healthcare professionals who care for these complex patients often listen to the show. So, Dr. Goldstein, can you start out by telling us why this population should be interested in sexual health?
Oh my gosh. How many hours do we have here?
Right.
Well, connective tissue, let's argue, is really important towards everything and anything we do, and sex, clearly. And the mechanisms of sex, like the neurologic transfer of information from the genitals to the brain, has to pass through the spinal cord area. And in the spinal cord area, there are discs, and the discs are full of connective tissue. And people who have connective tissue problems get tarlosis and annular tears, and those things sort of change the course of the sacral spinal nerve root that's carrying all this cool information to the brain, and it causes it to be irritated, and then people get unwanted, unhappy feelings called dysesthesias, including unwanted arousals and stuff like that. So for at least that reason. But there's another important reason, and that's the vestibule is the entrance to the vagina. And there's a crossing, got to get my hands in here, crossing of the conditions of people who have aberrant mast cell activity. So that's those Ehlers-Danlos is an example of a condition with aberrant mast cell activity. And there are women who have pain during penetration, even as early as their first tampon, that fits into this mast cell aberrant condition sort of syndrome. That's called neuroproliferative vestibulodynia. So we'll see them from a vestibulodynia perspective. We'll see them from a neurologic perspective. And sadly, it's extremely common.
Sure. And vestibulodynia is pain in the vestibule. Is that
right?
Correct? Okay.
You can
Excellent.
have nosodynia, chin-odynia, forehead-odynia, and vestibulodynia.
Now he's just being silly.
Okay. So I feel like there's just so many different ways in which these conditions can impact sexual health, because when I was asking for people for questions, and we have some great questions that we'll address in the second half of the program, people were asking questions about things even like sexual positions and things like that. So there's a lot of different ways, right, in which these conditions can impact the ability to have sex.
No question about that. Sue, you talk.
No, really, there's two different things going on with that last comment that you made, Linda. I mean, the ability to have sex, if you physically need to move a certain way and your EDS keeps you from being able to bend a certain way, or you're going to bend too far and injure yourself. But then, the mast cell conditions that you might have if you have irritable bowel syndrome and IC, interstitial cystitis, you may not feel comfortable having sex. You're afraid of what's going to happen. But vestibulodynia, it just hurts. And it's not just hurting during sex. It may hurt to wear tight pants. It may hurt to sit for a long time. So that it really impacts your quality of life. And I think sexual function becomes a major indicator of quality of life. When you have to stop having sex, it's a huge deficit in your quality of life.
And can definitely impact relationships. And of course, relationships are important. So it can start kind of a downward spiral that can be really, really problematic for people.
But the good news is, sorry, you talk. No,
these people have I have a patient right now who is in nursing school, and she's had to take 3 semesters off until she can get, all of this taken care of, because she can't sit in a classroom. So it's not just the sexual part, even though it's a sexual organ, if we're going to talk about the vestibule, but it can stop you from just plain living.
Mm-hmm. So we didn't talk about endometriosis, which is another associated condition with Ehlers-Danlos as part of a condition with aberrant mast cell activity. Mm-hmm. And endometriosis is just awful because your periods are ridiculously painful. You bleed a lot. Penetration is okay. It's the thrusting that that knocks you down, because typically the endometriosis is involved in the uterosacral ligament, which is the thing that holds the vagina in place. So if you move the vagina, you move that ligament, which causes pain. So there's countless issues.
And again, you're missing days of school, you're missing days of work because your menstruation is so painful from the endometriosis, far beyond the people who just have, more common dysmenorrhea. So your life is really impacted with any and all of these mast cell aberrant, conditions.
And that's an interesting distinction between pain with penetration versus pain with thrusting, because I feel like most doctors are not going to ask those really, really specific questions, right?
Well, either they're not knowledgeable enough to ask the questions or they're not comfortable enough having the conversation. I mean, there's a lot of research that shows that patients are fearful of embarrassing their doctors if they bring up a conversation about sexual function and they want their doctors to bring it up. But the doctors are not comfortable having that conversation, either because of their own background, their lack of knowledge, their religious upbringing, or just the fact that they have 12 or 15 minutes to have the conversation. And one of the things that we teach at the International Society for the Study of Women's Sexual Health is start the conversation. And the patient says, yes, she has an issue. So you know what, Mary, this is such an important conversation. Let's schedule another appointment just to have that conversation. In that moment, you've told her, this is a safe space to have this discussion, that you are not alone because clearly he knows what you're talking about. And that either he is going to help you or his nurse practitioner is going to help you or he's going to find somebody else to help you. But the three most important things, you have validated this for the patient and made her realize she's not alone, which is one of the huge struggles. And I think one of the blessings of the internet is that people are able to find out that they aren't alone, that other people have this problem. But one of the problems with the internet is that they get a lot of bogus information.
But I want to say something. You're talking about doctor learning. What's amazing about this current era is the podcast, the Bendy Bodies, all of these support groups on the various Reddits and Facebooks. The information is happening at fast pace now. I just had a woman in the office with this neuroproliferative vestibulodynia who had it all her life, and she was informed, "Oh, go have a glass of wine," or one doctor actually told her to have more orgasms because that's what will stop her problem. I mean, really ridiculous information. And she got care while she was in her 50s. And basically, her whole life, she's had this condition. Whereas we're now getting kids who are 18 years old and 20 years old who are saying on support groups, I can't have sex. What do I need to know? And blah, blah, blah. And they're learning about neuroproliferative at an early age and getting care. My last 4 surgeries were done in individuals who were born after the year 2000. It's pretty amazing.
Just shows how old you and I are getting. But it's true. I have a mantra. It says the educated patient is the empowered patient. And the more education that we can get out through sources that are available. I mean, last year we published a paper on vestibulodynia and we convinced the editor to allow it to be open access. That means that it was available for people to read. And the rationale I gave him was that physicians either have a subscription to that journal or have access to the journal, but patients don't. And they're the ones that need to know because they're the ones coming up against the gaslighting. They're seeing clinicians who don't know enough about the disease state to recognize that there's nothing to be seen when they are on exam. And that doesn't mean there's nothing wrong. I mean, my husband taught me 40 years ago, listen to a patient long enough and they will tell you what's wrong with you. And when you have that 15-minute visit, you don't always have a chance to do that, which is why in our office, for instance, they sit down in Irwin's office for an hour before we even examine them, because we want to listen to every nuance and we want to give women or all patients, the respect that they know what's going on. They may not know why it's going on. They may not know the diagnosis, but they know what's going on in their bodies. And we have to respect that and not gaslight them. And so that's why having educational material available to all people. So thank you for doing your podcast so that more people have access to this information.
And not to keep this going crazy, but the Tarlov cyst thing, I mean, I kind of tell you how many people are told all Tarlov cysts are incidental. They don't mean anything. They don't do anything. In my experience, Mrs. Jones, your Tarlov cyst they're going after the wrong thing if you think it's a Tarlov cyst. I mean, I don't get it, but a Tarlov cyst really displaces the sacral nerve root. I mean, give me a break. And there's plenty of evidence that I mean, the key evidence is getting a lidocaine injection where the tarlov cyst is to numb it. God bless. If your symptoms significantly reduce, give me a break. What other conclusion can you draw?
And that's exactly what happened to me when I had a selective nerve root
Yay!
block. Yes, my pain went away 100% for the first time in years. And
Amazing.
it was amazing. And I had surgery with Dr. Frank Feigenbaum, and that's how I found out about you. And I've interviewed him on the podcast. So we have an episode about tarlov cyst, and we can link that in the show notes as well, because people definitely should check that out. I find such a huge number of my patients have tarlov cysts. And like you said, they're told
they're all incidental. They're not
exactly
something else.
Yeah.
Well, again, it's lack of education on behalf of the provider who's saying that. Unless they have an interest in learning more about, the sexual health issues that can occur from it, that information is not going to come to them. They have to seek it to learn it. So I always say to our patients, go back to your doctor who didn't know better and tell him or her about this information. So maybe the next patient won't have to struggle for so long finding help.
Mm-hmm. Yeah, that's an excellent suggestion. And tarlov cyst can cause so many other symptoms, right? Because like you said, there's sacral nerve roots, which actually are going to supply more than just the perineum or the...
Okay, Linda, let's do a pop quiz. Tell me the three nerves. Yes. Tell me the three nerves in a sacrospinal nerve root. Say the word pudendal.
I was just going to say pudendal that was the one that I was going to say.
Say the word sciatic.
Sciatic. Okay.
And say the third is pelvic.
Okay.
So pelvic is the inside of the clitoris. It's the bladder. It's the rectum. It's the vagina, the cervix, the uterus. The pudendal is all the external stuff from the clitoris down to the perianal area. And the sciatic is your butt and your thigh and your calf and your toes and your feet. So all of these weird symptoms that confuse people, if you have in a symptom complex, something related to your lower extremity, like your butt or your toe or your leg, something related to your front, like your vulva or the perineum, and something related like to the pelvic nerve, like your belly button. It's weirdly sensitive. Was yours weirdly sensitive?
I don't remember that, actually.
Okay. It's a pelvic nerve thing. But my whole point is that there's nothing else that can cause these symptoms coming from one pathology other than the tarlov cyst and the annular tear. Now, the weirdest part of having EDS is you can have both an annular tear and tarlov cyst because they're both connective tissue related. And we have to do a lot of more detective work to figure out which is the one causing the pathology. But we do that.
But we see patients with itchiness in their crotch, and everyone assumes they have a yeast infection, and then they give them treatment, and it doesn't do anything. Well, because it's coming from the sacrospinal nerve roots. Or burning when they pee, and they assume that they have some kind of a urinary tract infection, but there's nothing when you culture them. It's because it's coming from sacrospinal nerve roots. So things can happen in one part of your body coming from another part of your body. And for people who have spine issues, it can affect anything in your lower body. And one of my friends always calls it a sex detective, because that's what we are. We have to figure out listen to what's happening and then figure out where is the problem, where is the pathology actually occurring? Is it at the location of the problem or someplace further upstream? So
check out the full Bendy Bodies podcast episode on your favorite podcast app.